Welcome everyone to today's webinar, Transforming the Trauma Performance Improvement Program at Mary Bridge Children's Hospital. I'm Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Dr. Tony Escobar is a pediatric surgeon and medical director of pediatric surgery and trauma at Mary Bridge Children's Hospital in Tacoma, Washington. Dr. Escobar recently completed 2 terms as the hospital's chief of staff. He graduated from Baylor School of Medicine in Houston and completed his surgical residency at Indiana University, where he served as chief resident in his final year. He then completed his pediatric surgical residency at Women and Children's Hospital of Buffalo, once again serving as chief resident in his final year. Jennifer Brown is a consultant for the Healthcare Transformation Services business within Philips. She graduated from the University of Alabama, Birmingham with a master's in nursing and has certifications in nursing informatics, clinical nurse leadership, and nurse executive administration. Earlier in her career, Jennifer spent more than 10 years leading technology-driven emergency and trauma process improvement initiatives at a pediatric level 1 trauma center. Since then, she has served in numerous emergency and trauma leadership roles in academic and community hospitals. Angie Chisholm is a consulting manager for the Healthcare Transformation Services business within Philips. Angie has served on many state and national trauma committees. She is a trauma-certified registered nurse and a certified flight registered nurse. She is a passionate, results-driven leader with nationally recognized expertise in trauma program operations. At this time, I am pleased to turn the floor over to Jennifer to begin today's presentation.
Thank you. This is just a slide again of everyone, our team that's on the call today. A picture of Dr. Escobar, myself, and Angie. So a little bit about Mary Bridge to start us off is Mary Bridge Hospital, Children's Hospital, is part of MultiCare Health System. They joined the MultiCare Health System back in 1980. They are also only one of 2 pediatric trauma centers for the state of Washington, and in the western region, they are the only children's hospital and state-designated Level 2 trauma center. They're licensed with 82 beds. They have 24-hour pediatric emergency department, only for pediatrics, 2 dedicated outpatient surgery suites, an advanced pediatric inpatient surgery center with rapid response environment controls, and more than 30 outpatient pediatric specialty clinics. I'm going to turn the next slide over to Angie. Angie, I'm unable to hear you. Are you on the call? Are you on
Yes,
mute?
I'm sorry.
Okay.
Yes, I'm sorry. Thank you. Allow me to tell you a little bit about Philips Healthcare Transformation Services. Philips is well known in healthcare for their equipment like monitors and CT scanners, and more widely recognized by consumers for the toothbrush. But did you know we offer healthcare consulting services? We are delivering solutions-oriented and people-focused recommendations to help improve clinical care, patient experience, operational effectiveness, and financial performance to ensure sustainable results for long-term success. We have over 50 U.S.-based consultants with clinical IT and healthcare leadership experience, and a global network of consulting expertise in 7 countries. Today's presentation is just one example of what we can do. So for today, we aim to provide you with an understanding of the importance of performance improvement on the trauma center designation process while helping you identify the critical deficiencies that lead to a site survey failure. We will also discuss the impact that vacancies in key positions may have on the trauma program and the designation process. Now, I believe Dr. Escobar may be on, and he is in emergency surgery. Hi. So I am going to, no worries, patients come first. So I am going to let Dr. Escobar give you the information next.
So thank you, everybody, and I really appreciate your patience. So in February of last year, we had the experience that every trauma team dreams of with an extraordinarily difficult site review. And as many of you have experienced, at the heart of the findings was our PI program. And so our trauma program went through many changes following that site review. But one of the critical key elements in trying to recover from the site review and address the findings that the Department of Health had for us was to surround myself with an experienced team to be able to address those PI issues. And so we vetted many applicants, but ultimately chose to go with Philips Blue Jay because I had worked with Angie in the past through the Trauma Center Association of America and knew the credentials that she brought. And then I was extraordinarily fortunate to meet and work with Jennifer Brown on the ground to essentially rebuild our trauma program from the bottom up. And although PI was a key finding, there were many elements, as most of you could imagine, that had to be addressed as well. And we really took the program and looked at it as an opportunity to rebuild it from the ground up. And what we've come out with on the other end is so much more robust. And I think it tells our story so much better to the site reviewers, to the state. And I won't skip to the punchline because I'd like Jennifer and Angie to be able to present that part. But the experience has been extraordinary. And as a trauma medical director, the growth for me personally has been absolutely extraordinary.
Thank you, Dr. Escobar. So moving on, as Dr. Escobar said, is that we got brought in. The survey actually was in February. And one thing that's so amazing about the Mary Bridge team, and also I think one of the things that makes them a leader, is they did not wait for the state's final recommendations to come out in April. Actually, in February, they already started making a plan. And Dr. Escobar worked with the leadership team and coming up with, let's move forward and let's make this an even better program than it was before. So one of the great things is, before we even arrived at Mary Bridge, Dr. Escobar sent us a copy of all his notes from the final report out of the survey, and that really helped Angie and I determine how we were going to come in and start making the improvements and working with the Mary Bridge team. So we made a decision to use the PDSA methodology, and so we came up with the plan and on what we were going to need to change and what we needed to focus on, and then we carried that out. And then, of course, we observed and studied the data behind it, and then made any kind of modifications or changes that we need to make to go on and carry that out to act to sustain that performance. So again, part of your plan that is so important is that we slow down and we take the time to truly know and identify what the problem is. So again, following the regular scheduled trauma site survey, the team identified that there were critical deficiencies in the performance improvement processes. And these included failure to perform adequate primary and secondary case review, as well as missed opportunities for adequate loop closure and feedback to providers, leading to failures to improve care for the benefit of future patients. So the goal of our project was very important, that when actually, when the state did release the findings in April, what we found out was, I think what the team expected all along is that there would be a corrective action plan. And with the corrective action plan, the state of Washington gave a date that they wanted to see the changes in place and also show that these changes had taken place by October 31st. And so that was to meet the state of Washington requirements to retain the Level 2 Pediatric Trauma Center status. So also part of the plan included one of the most amazing teams. So having a good transformation team, which of course included Dr. Escobar as the trauma medical director, and I've been able to serve as the interim trauma program manager, and Heidi Mallory, who is our lead trauma registrar, as well as Hillary Lindley as our trauma registrar, and Angie is our consulting manager to help directing us along the way. And then I can't say enough about the leadership team at Mary Bridge, about how proactive and how involved they are and how much they want to see the trauma program succeed. Very supportive group of people. And then, of course, the key department stakeholders. Everyone was very involved in wanting to make sure that we had this taken care of. So at a very, very high level, what did we do? Again, very, very high level. There's a lot behind this, of course, is we developed a corrective action plan for the deficiencies. Now, in that also included was a dashboard of key performance indicators. And then, of course, what we did was, in focusing on performance improvement before what was being used actually to track performance improvement was an Excel spreadsheet. Well, with an Excel spreadsheet, it doesn't necessarily allow you to be able to really monitor and track and trend. So a decision was made, and the hospital supported purchasing a PI database to be able to make sure that these activities that were being done and going to be done were documented well and then could be tracked and trended. And then it is so important for benchmarking, and so TQIT participation, we joined TQIT, and so we could begin national benchmarking against other Level 2 pediatric trauma centers. The first thing we did, of course, is we had a timeline. We had to meet an October 31st deadline. So we created, again, what are those key things, tasks that have to be done in order for us to make the October deadline? And those are identified here. Now, we talked about having a PDSA, but each of these items also have PDSAs and even PDSAs in there to make sure these things happen. So the problem identification was one of the first steps that we knew needed to be done, and that happened in March and in April. Really in April, when we got that final report, we were able to see that the notes that Dr. Esquire and actually Heidi had taken well were right on target. So there were not a lot of surprises, maybe one or two that we were able to very quickly work through, but we were able to determine and find what we needed to work on. And again, as I just got through talking about, is we implemented a PI database. We had that up and going and being able to input data as of May. And then in June, we were able to accomplish revising the job description of the trauma program manager. So in hiring the permanent trauma program manager, we would be able to set them up for success. The creation of audit filters to make sure that we have a structured methodology for collecting data. And then again, we talked about developing a key performance dashboard. Those things were all completed in the June timeframe. And then the PI revision, or the performance improvement policy, we needed to make sure that the policy matched the practices that were taking place, and also included, the other thing very interesting, is in January, the state of Washington had updated their trauma standards. So there were new standards, and those rules needed to be referenced as well in this policy. So we were able to get that done and approved through committee process by July. And then reduce registry backlog. Before, when they were working with just the state of Washington, the goal was to have everything abstracted within 90 days of discharge. But moving to TQIT, that was a more progressive plan. So we needed to make sure that abstractions happening at 60 days after discharge. And then, of course, our goal of implementing submitting to the state by October 31st, which I have great news to share with you about that in just a minute. So the specifics of what the state, it seems this isn't coming up on the slide, so I'm going to, give me one quick second so I can make sure I have those for you. So I was going to share with you specifically what the state said. So the recommendations that they gave, the first recommendation is, of course, they wanted to see an improvement of the collection, monitoring, analysis, and reporting of the data to drive quality improvement. And what better way to do that than to have a PI database to help do that? So there we go. So we were able to implement the PI database to be able to do that for quality improvement. The next finding was, of course, to improve to perform the primary and secondary levels of review. A part of that, even if you are doing the primary and secondary review, it is so important to document those things. So we revised the process to ensure that not only the primary and secondary review were being completed, but also that we were documenting those meetings that were occurring. So to track the audit filters across the span of the continuum, there we implemented audit filters and created, also we implemented those audit filters and created the dashboard for those. And then regular reporting and benchmarking of the metrics. So again, creating a dashboard, the scorecard to make sure that we can get that done, and then, well, of course, implementing TQIP. So Angie and I thought it was really important that we showed you what a dashboard looks like. So this is actually the one we created for Mary Bridge. This is not meant for you to actually see any of the details, but to see what it looks like. On the left, of course, are all the different audits that we're conducting. And then also we had a target that we have created for each of those specific audits. Then over to the right is that they would have specific data. It could be a percentage or a number that's in each of these fields. But using green saying that we are sustaining and meeting the target, and red being areas that we need to look at further and make plans around. So we went through a lot. It was a lot of work, but the results were absolutely worth it. So we were able to actually submit the corrective action plan by September 23rd. And with the due date of being October 31st, we were ready to submit a little bit earlier than expected. The written plan that we actually gave back to the state included that revised job description and the revised PI plan, as well as the scorecard I just showed you on the earlier slide, as well as showing them case summaries that demonstrated the different levels of review, also including, of course, any kind of systems or case review meetings, and then the loop closure around for the event resolution for those cases for the state to see. So lessons learned is that it is so important to identify the right stakeholders and have them in the right meetings at the right time. Also to make sure that our team is ready and that they understand what we're going to be doing and making sure those things are carried out. And then education around any kind of new standards that a state has. So having early education to understand what those are and making sure that the team knows what will be the new changes coming forward. And then, of course, it's so important for all of us to constantly to make sure that we're continuously giving feedback, clarification, and communication. So next steps to sustain this great performance that we have is we are continuing our PI process and documentation of activities. And then also with the next steps included are the way the state of Washington says that instead of weaknesses, they say here are the recommendations that we want you to take a look at and fix. So our next steps that we have been working on is, of course, resolution of any identified weaknesses, and then ongoing compliance of the new trauma center standards. And we are working with the team to recruit a permanent trauma program manager. So those areas or those weaknesses, as they could be called, or recommendations of the state, they are here. And whoever helped me again last time, if you could do that for me again to advance this, was to demonstrate the compliance of the new state of Washington standards at the time of redesignation in 2022. So what we did was we created a gap analysis to look at each of the changes that the state wanted to see if they were already in place at Mary Bridge, or if it was something that we were going to need to work on a little bit further and have that completed and demonstrate that it's happening by 2022. The outdated PI/QI plan that we had regarding the rule reference, that was part of what we presented, that we completed actually in July. And it contained that new rule. Part of when I talked about earlier that we made changes to the trauma program manager job description, we went ahead and included topic as being one of the courses we want to have seen that this trauma program manager has taken, or that we can have them take within a period of time. I completed the topic course, and then again, of course, like I just said, that we made sure we added that to the job description. Providing follow-up to EMS regarding patient care issues. One of the things that has happened as part of our process is we have an amazing, actually pediatric emergency medicine physician who serves as our EMS coordinator, and she and I meet monthly, and we review these EMS audit filters that we have put in place. We review those, and we look for opportunities to give feedback to our pre-hospital team. And I think there's one last one. And then, of course, to demonstrate the trauma surgeon arrival time. Now, Mary Bridge is very innovative, and they had the ability to do badge swiping for the team as they arrive. But the problem with that is the badge swipes were not interfaced with the actual electronic medical records. So what we've done is we've implemented that the nurse scribe in the trauma documents those times in the electronic medical records. So Angie, I'm going to turn this over to you now.
Thank you, Jennifer. I think it's worth noting that the Mary Bridge leadership, including Dr. Escobar, recognized the need for support and acted very quickly, which is why we were able to meet that deadline for the resolution. So what we're going to talk about in these next few slides is actually how to avoid these criterion deficiencies and how to better prepare for a site survey. I will note that the Mary Bridge team were not making mistakes, if you will, with their PI. They just needed to enhance it a bit and document it a bit better. They were providing excellent patient care, as they continue to do today, but they needed to gather that information and make a proof point of that information. So there are a lot of people on the call and a lot of different backgrounds, so we're going to get a little basic here just for a minute, so bear with me. I just want to make sure that everybody understands the context of what we are trying to present today. So what is a trauma center? It is a hospital that's equipped to care for the multi-injured patient throughout the continuum and has also undergone a review of compliance with trauma center standards to become designated or verified. There are two different definitions here. Trauma center designation is state-based. The criteria varies from state to state. It is rule-based and many times outlined in law through legislative or regulatory authorities. Trauma centers undergo redesignation surveys depending on the state agency, sometimes every 3 years, sometimes up to 10 years. The trauma center verification is different, however. The American College of Surgeons Committee on Trauma does verify that the standards are being met to operate as a trauma center. They started these guidelines back in 1976 with their first book, The Resources for Optimal Care of the Injured Patient. Today they are on another edition, which is we call the Orange Book, which is our Bible if you are an ACS verified facility. The trauma centers undergo ACS verification every 3 years. So if you're ACS verified and state designated and your cycles don't match, you may be in perpetual survey mode. Participation is optional, or it may be required depending on your state requirements. So what is a site survey? It's many times just like a Joint Commission survey. It's a team of trauma experts. They complete an on-site review of the hospital and provide an objective external review of the trauma center's resources and performance. Some of the things that they are looking for, these surveyors, is the commitment of the hospital to the trauma program, the readiness of the trauma program in caring for those patients, the resources available to the patient to make sure that you have all the resources to the level of trauma center that you are being designated at, that they have all the recommended policies and guidelines to care for the patient. They look at the patient care, they review the EMR, and they also look at your performance improvement documentation. Trauma center surveys take a significant amount of time and money, upwards around $20,000, depending on which organization that you're working with. And that's why it's so important for you to get it right the first time. A typical preparation period can be 14 months. I've seen it done in as little as 6 months, but that's pretty labor intensive. The site survey reporting year is a full 12 months. It's not very quick. So what criteria are you being surveyed on? I have a copy of this orange book here, and behind that is just a screenshot of a state standard. I'm going to talk about the ACS criteria because that's standard across all states if they participate with ACS. As I said in the previous slide, state standards may change between states, and it would be pretty difficult to review all 50 of those in this presentation. So we'll talk about the ACS. There are two types of criteria that you must meet in order to be verified as a trauma center. There is type 1 criteria that must be in place at the time of the verification, and type 2, which is also required but less critical. The survey team determines if the trauma center has met the obligations of the rule or standard and provides a summary of strengths, weaknesses, or opportunities for improvement, and deficiencies. The classification terminology may be different depending on the state's process, but the intent is the same. Is the facility compliant or deficient in meeting the standards and rules? So how do you avoid those site survey deficiencies? Well, according to the ACS, essential requirements for verification include compliance with type 1 and type 2 criteria, as we just discussed. They go on to say if any type 1 or more than 3 type 2 deficiencies are identified, the facility fails to achieve verification, and a focused review must occur 6 to 12 months from the initial site visit at an additional cost. If fewer than 3 type 2 and no type 1 deficiencies are identified, the facility can get a 1-year certificate, but they must correct the deficiencies. I tell you that the site survey is not the time to identify that you have a gap in your program. And if this story sounds familiar to you, it is very common, and that is why we are able to help. So no program is perfect, but they should have a continuous improvement process in place with documentation of PI activities. The minimum standards of designation and verification must be in place or face jeopardy of closing, downgrading, or given provisional status. These are 5 common reasons why your program may be in jeopardy. Registry noncompliance, that is noncompliance with your data abstraction. Your PI compliance, failure to demonstrate that loop closure or document your case reviews. Your call schedule coverage gaps. Physicians and nursing education inventory is incomplete. And a vacancy in a key position. These are just some common reasons, again, that your program may be in jeopardy, but it's certainly not an exhaustive list of potential areas of opportunity. So how do you find out if you are in jeopardy? Do it by asking the right questions. So when is the next survey is probably the most important question that you would want to ask. Whether you are the senior administrator responsible for the trauma program, you're the trauma program manager or director, you're the trauma medical director, it doesn't matter what your role is. Everyone should know when the next survey is so that we can have a complete state of readiness for that survey. Some questions you can ask of your registry. What is the trauma registry inclusion criteria, and are you capturing all of the relevant data? Ask to see that information. Ask to run a report of that information. What is the registry abstraction rate? Is it 80% within 60 days of discharge? That is the ACS standard, And you heard from Jennifer that the Washington standard was different. It was 80% within 90 days of discharge, but that doesn't marry up to the TQIP participation. So making sure that you're meeting the obligation. Do you have any vacancies, any open positions in registry, your PI program, your leadership, any surgical specialties with vacancies where you can't have a complete call schedule? Those are all questions to ask and things that will put your program in jeopardy. Looking at physician qualifications, when was the last time that you performed a physician qualification inventory on each specialty on the trauma call panel? Making sure that all of your physicians and surgeons are board certified in their specialty, making sure they have the CMEs, making sure that they have ATLS if it's required, making sure they're credentialed appropriately to provide that level of care in your trauma center. That should be done every year and kept up with year over year. Performance improvement, can you show me 2 examples of loop closure from recent cases? Ask to see that information. How many cases remain open, and are you concurrent in your chart review, or do you have a stack of charts that you cannot get to because you have a vacancy? Are the physician liaisons actively participating in peer and system meetings? What is their attendance compliance? Ask to see that. Review the performance dashboard. If you don't have a performance dashboard, then create one. Review the PRQ data tables, the pre-review questionnaire. So prior to any survey, you're required to, 30 days out, provide a document called the PRQ, pre-review questionnaire. Some states have an RFP, request for a proposal. But those have data tables in them. I recommend that you run those data tables, a data analysis, every year. Make sure that you have that information in front of you at all times so that you understand what your program is being measured against. And it's not 30 days ahead of time trying to figure out what that data means to you. Nursing qualifications to go along with physician qualifications. When was the last time you performed a nursing education inventory? The ACS, many states are very prescriptive about nursing education, but the ACS, however, is not quite as prescriptive. But it is valuable to run that inventory of each of your care areas and make sure that your nurses are qualified to care for your patients. So when was the last time that you did a gap analysis? Getting a list of all of your standards and seeing how you meet those. How can you prove that you meet those standards? PI compliance, for example, is evident at the case review meeting. Look for cases that are more than 3 months old for an idea of how concurrent the case review is. So talking about the fallout from vacancies, this is why vacancies are so important not to have in a trauma program. Trauma program personnel have unique skills that are not intuitive to typical clinical or leadership staffing, leading to a difficulty in hiring. You also, it's very difficult to just take a leader that's in the hospital and move them into the trauma leadership role. They can learn the role because we all do. That's how we all get started somehow. But it is not that easy to just walk in and be successful in a trauma program manager role or a registrar role. I've worked in facilities where the senior leadership wanted to remove the trauma registry and just have a cancer registry doing all of the abstraction. Well, cancer is very different from trauma and the data points that are abstracted. So you need to know what skill set is required of all of your key positions. A vacancy in a key position, according to the American College of Surgeons, may be viewed as a lack of commitment. If you are allowing vacancies to continue in your facility, then it may show that you aren't committed to the success of that program. As I said earlier, an active survey period is 12 months before the actual site survey. So this is not a last minute throw someone into the position and hope that we can pull this off. So for proof of all of this, Criterion Deficiency 2.1 in the American College of Surgeons book, the trauma center must have an integrated concurrent PI and patient safety program to ensure optimal care and continuous improvement in care. That is a type 1 deficiency. So if you have a vacancy in a PI nurse or a trauma program manager or director, and you are not concurrent in your chart review, that is a type 1 deficiency. Criterion deficiency 5-23. In level 1 and 2 trauma centers, the trauma program manager must be full-time and dedicated to the trauma program. That's a type 2 deficiency. And if you'll remember, if you get one type 1 or any type 2s, or more than 3 type 2, you're not moving forward with your verification. So that's why these vacancies are so critically important to your program. That's why you also cannot just take a leader from another area. I've seen where ICU directors are also given the trauma program responsibility, or the ED director is also given the trauma program responsibility. They cannot possibly split their time between the two, especially in level 1 and 2 facilities. So criterion deficiency 15-9, one full-time equivalent employee dedicated to the registry must be available to process the data capturing the NTDS data set for 500 to 750 admitted patients annually. That's type 2, so a vacancy there. And all of these listed here, all of these criterion deficiencies listed here are type 2. So all surgeons and physicians on the trauma call panel must be board certified in their specialty or follow the alternate pathway. So there's an opportunity for at least 8 type 2s if you have one physician in each of those specialties. As a reminder, if any type 1 or more than 3 type 2 deficiencies are identified, the facility fails to achieve verification and a focused review must occur 6 to 12 months from the initial visit at an additional cost. So how do you avoid these deficiencies? Ask the right questions, review the data and know your numbers, whether it's a dashboard of key performance indicators, whether you run a report of your PRQ tables, and understand what is going on in your program. Clarify the rules or standards with the governing body. I participate in a lot of listservs where there are lots of questions about how to interpret different rules. I recommend that you always go to the source and get clarifications on the rules and standards. And if in doubt, consult an expert. I want to conclude with this, that no trauma center should run the risk of a deficit, underperformance, or closure from being ill-prepared for their site visit. Trauma is very important to the hospital's bottom line, but I think it's more important to the community it serves. So thank you for giving us your time and attention today. I'm going to pass this back to the moderator for any questions that you may have.
Great. Well, thank you, Dr. Escobar, Jennifer, and Angie for such a fantastic presentation. We'll now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We'll try to get through as many questions as we have time for. The first question is from an audience member who is asking, what key audit measures or key performance metrics were most challenging to achieve?
Well,
Jennifer, Dr. Escobar, I'll let you.
Yeah, I was going to say, I'm sure that from different points of view, there's going to be a slightly different answers. But the one that, for me, just intuitively trying to get around was not necessarily documenting the appropriate activation of the trauma surgeon, which at the end of the day, as long as they showed up to the majors and somebody had noted it, even if I just signed in on a piece of paper, that was fine. For me, the difficulty was trying to define orthopedic surgery or neurosurgery appropriately responding, and how did we document that? And we're still working on that. The other key piece, and then I'll turn it over to Jennifer, was what if you disagreed with the site reviewers? And so my academic interest lies in child abuse screening in trauma centers, and I'm heavily involved in the creation of those kind of screening programs. And I disagreed with the site reviewers in a certain recommendation regarding child abuse screening. So, I was prepared to write a rebuttal because I did not think that we should just implement that particular recommendation. And so those are the two things as a medical director that I found challenging. And Jennifer?
Yeah. I'm just making sure I wasn't still on mute. So you're right. That was one of the ones that we found. So to start off with, what we did was we worked on those, as I had in the PowerPoint presentation. Those were key. We're all in agreement, and these are the ones that we're going to work on. What we have done, as Dr. Escobar said, is what we've done is this hospital is so amazing that they actually have a subcommittee of our trauma committee that is focused on child abuse. So what we have done in that committee is we have continued to discuss it and look at what exactly the state was wanting from this particular weakness that they identified and the findings around it. So what we'll do, our next steps, or what we're working on, is to make sure that we've gotten clarification from the state. There was one other in Dr. Escobar that we had that we really weren't sure what the state was saying. We didn't necessarily agree with it. And on that particular one, what I had done is I emailed the state and asked them, here's where we don't necessarily agree with you or understand what you're saying, so could you please clarify or give us more information? And so we were able to partner with them and actually come up with a solution, and it is documented now, in email, that this is what we agreed upon that we would do to meet that weakness. And Angie, do you have anything to add?
No, I think just changing the process of evaluating the care and documenting it in a different way was initially a challenge, but we quickly were able to overcome that challenge. And I think, honestly, the PI meetings that I've been able to attend have been very robust discussion and debate and conversation, which is very healthy in a program to have that input from and participation from the different subspecialties. So I think actually Mary Bridge is well on their way to making great improvements in their program.
Wonderful. Thank you all for weighing in on that question. The next audience member is asking, did you add anything else to the TPM job description besides the topic course?
We did, and of course, Angie and Dr. Escobar, please add in anything that I forget. As far as with the qualifications, we did believe that in working with our CNO and ACNO, that this person needed to be a master's level prepared nurse and have current certification in TCRN, a trauma course for nurses, and then, of course, having the topic course that we had. Also with that, we also wanted them to have prior experience in the role of a trauma program manager.
No, I think this is Dr. Escobar.
Yeah, go ahead.
Yeah, I think Jennifer really, really nailed that. For us and for me, I think that one of the huge lessons I took away from this site review is the absolute critical nature of the dyad relationship between the trauma program manager and the trauma medical director. And while over the years I have absolutely learned a lot about trauma program management, I am by no means as smart as my trauma program manager. So it took quite a bit to realize that and add to the job description those qualifications that, although I can talk about PI and QI, I don't live in it. I'm not elbows deep into the actual way that we note it, loop closure. I thought we were doing everything just fine. And then clearly we couldn't demonstrate that we were. And those were the extra qualifications that I think were critical. One other piece that Jennifer didn't address was that, but Angie mentioned, was being careful not to add too much to the trauma program manager job description. There's a tendency to want to combine positions to save on FTE at the organization level, and that is absolutely not in the trauma program managers or the trauma program's best interests. So the trauma program manager at a level 1 or level 2 should not also be the the injury prevention person or the registrar or et cetera, et cetera. And I think we really clarified that within the rewriting of the job description.
Perfect. Thank you for elaborating on that. This next question is the trauma registry the best place to document case summaries of closed PI cases?
I can take that, Jennifer. I've had experience across the country in very different formats and platforms with trauma registry or PI capture and documentation into a database. And there, believe it or not, there are many places who use Excel spreadsheets to capture their PI. And you can't query an Excel spreadsheet, which is why I lean towards the database, whether it's a homegrown Access database or SQL database or whether you purchase one. It is just so important to have your information in a place where you can query and research. Whether or not the registry is the most appropriate place depends on the type of registry that you have and the platform that you have. We work with the Digital Innovations product at Mary Bridge. The state of Washington works with that product. And so they do have a separate database that's integrated in the registry. I think that's the key, is if it can be integrated where you're not duplicating efforts and you're not abstracting records twice because you're doing it once with the PI and once with the registrar, but yet work together. I think that's a better model, and it creates more efficiency that way.
Absolutely. Thank you so much for weighing in there. Another audience member is asking if you're able to provide a little bit more detail on the insights and challenges for key stakeholders who were involved in the project over time.
Perhaps I can take this one. I cannot stress enough that this is a 14 to 18 month project. We were at a bit of a disadvantage this cycle because we had some significant changes, which actually ended up being for the better in the state in terms of the requirements. They completely changed the application. Dates started getting pushed out. And so through actually no fault of our own, but again, I believe in the end was better for the state, we actually didn't have a target date until quite late. So we were already behind the eight ball, if you will. In regards to key stakeholders, I think it is imperative that the trauma medical director and the trauma program manager have the ear of your senior administration, your CEO, your CMO, your CNO, your COO, as well as the board. And so, although this was a little bit higher level preparation leading to the site review, I presented to the board the year prior. I worked very closely in reviewing the application with the then current trauma program manager. Worked with the CNO in preparing for that. What I did not see coming was the fact that we were unable to present the PI and QI work that we were already doing in a digestible fashion that really demonstrated that loop closure. And that was something that I didn't see coming because I think we used an Excel spreadsheet, honestly. And that was unfortunate. But so that's, but in preparation in terms of the key stakeholders, I partnered very closely with all of my C-suite, which, by the way, when we unfortunately underwent the site review that we did undergo, I was able to be on the phone the next day with my CEO and my CMO and start working to a plan. It is a record time that we were able to sign with Philip Blue Jay within probably a couple of weeks of that site review, knowing what was coming, the notes that I had, my discussion offline with the site reviewers and with the state. And so everyone was already prepared to support us. And that's invaluable. I don't know how many of you have ever had that experience where within a couple of weeks you have that contract signed, and we were getting to work within a month. That was incredible, and that was because of that, investment.
Yeah, Dr. Escobar, I think you bring up two good points, actually, and that is the reason, as I said in the slide deck, of how we were able to achieve that deadline successfully. We were able to submit the information ahead of time because of that quick action. But two things that you said that I think is worth noting is the reporting structure of the trauma program is so important. The trauma program should report to the C-suite and not up through any other avenue. You must have the ear of those senior leaders in order to get the support that you need when you need it. And the second thing that you said that I thought was notable is that you know that you're providing excellent care. You see it every day. You see it in your patient outcomes, and you took it for granted that you could prove that through your PI process because you knew the care was there. And I think that's the missing link for so many programs that struggle with their PI and their loop closure is just that documentation, which is labor intensive, but the documentation to prove that what you're seeing is accurate information.
Yeah, all great points to call out for our audience, so thank you both there. Another audience member is asking about the dashboard, and they're saying, could you give a few examples of the categories or the list of audit filters that were on your dashboard?
Yeah, I could answer that. This is Jennifer. What we did was the state of Washington gives you they've determined certain audits that they want to see within your dashboard or within your program. And so those, of course, are the ones that you definitely want to have on there. And so, of course, in addition to that is volume. And then also what we did is the items that we found as recommendations, we added those to the dashboard as well. And then other things that we felt that we needed to work on. An example of one of the audits that the state of Washington wants to see is the ED length of stay of patients who are transferred to an outside facility. So, for instance, Mary Bridge doesn't have a burn unit, so there's another hospital that burn patients are transferred to. So, to make sure that we're getting there within a timely manner. Anything else, Dr. Escobar or Angie?
I would just add that most states have discretionary audit filters and non-discretionary audit filters listed. The ACS also provides you with some recommendations for audit filters. So there are some standards out there, but you would also want to look inward at your own program and understand where your problem areas are. And number one, those go on your dashboard so you can keep track of your improvements.
And I'd also suggest that one thing that can happen is a trauma program can sometimes end up being an independent silo, which is where you have some real difficulties being able to tell your story and why the trauma program is so important. So your hospital is already going to have quality departments and others that will also have automatic filters such as CLAUDI, CLABSI, HAP-US, etc., to coordinate and collaborate, and it really broadens the view of what trauma brings to the hospital across other system quality improvements. So I would highly encourage you to have your quality person as well be a member of the multidisciplinary trauma committee.
Perfect. Thank you all for elaborating on that. This next question is asking, how were you able to narrow the identified deficiencies to the most pressing ones? Was that something that played out in the assessment process or not?
We were very fortunate in that the report was presented to us in a tiered fashion. Jennifer, correct me if I'm wrong, but there was you've got to address these or we're not going to be redesignated. And then these are the suggestions. What, as most have probably found, is that the suggestions become the requirements of the next cycle. So we really wanted to address every single one, but the pressing ones we wanted to address basically that first page that they sent us that were threats program. And as Jennifer mentioned, I'm going to let Jennifer finish that part of the story. We did submit by the end of September, well before the due date. And Jennifer, would you like to give the results of that?
Yes, the state, when they came back and they looked at what they had done, they were just so complimentary of the work that we had accomplished, and the fact that even in what we sent them for the case summaries, included examples of actual patients that they had brought up as areas of recommendations. They weren't the most critical, but that we had already started working on those. So each state is a little bit different. And so again, the way the state of Washington has it laid out is you have those things that are, critical. You've got to get it done now. Here are they call it highly recommended and then recommended. And so we've actually had a lot of fun, and we've really worked through. I believe we've looked at every one of them. We have plans around each of those, and even if one of the plans, the one Dr. Escobar pointed out, there are actually two of them that we didn't necessarily agree with the state or understand. And again, we're continuing to work on those. And we want to, again, with those things that the state recommend, is I think it's so important to show that you didn't at the last minute address it like, oh my goodness, we've got a survey coming up, that we started that immediately. So the next survey cycle is in 2022, and those things are already taking place.
Wonderful. Well, before we go ahead and end today's presentation, I just want to turn the floor back over to Dr. Escobar, Jennifer, and Angie. Are there any final thoughts that you'd like to share with the audience?
I think that the role of the trauma program manager is sacrosanct in the trauma program. And I just caution the listeners to not combine. First of all, I cannot stress enough Angie's point that the trauma department needs to report directly to the C-suite. The second is, in the era of cost savings, I cannot stress enough that there should not be a dilution of the role of the trauma program manager or addition of additional duties to that role, because PI/QI is the end-all be-all to prove that we are delivering quality trauma care, and we have to be able to demonstrate that, and that ultimately resides with the trauma leadership.
The only final thought that I would share is thanks to Dr. Escobar and his team and the leadership at Marybridge for being so willing to change. That made our job quite a bit easier, and we've very much enjoyed working with that team.
That's true. They've been wonderful to work with. I don't have any more remarks. I did notice there are several questions left. I think if we could probably email those folks with feedback for those questions.
Absolutely. We'll make sure everyone's questions are answered after the presentation, so thank you. That is all the time that we have left for today. I want to thank Dr. Escobar, Jennifer, and Angie for their excellent presentation, and to Philips for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.